Good evening, everyone. Today we'll be discussing about the usage of steroids in our day-to-day practice. We use that steroids in a lot of conditions like autoimmune conditions. We use it in some sepsis when the patient is not recovering from the shock, and also use it in meningitis. We use it in ARDS. There are a number of conditions where we can use steroids, and we'll be discussing about briefly about what steroids to be used in different kind of conditions. And first, before going into that, you need to understand what is the different kinds of steroids we actually use. We generally use hydrocortisone or prednisolone or methylprednisolone or dexamethasone. That is the normal steroids which we use in our day-to-day practice. So coming into the first thing, so when do we use hydrocortisone, when do we use prednisolone or methylprednisolone, or when do we use dexamethasone? So we need to understand the properties of these steroids before going into them. So hydrocortisone is more of a physiological steroid, so it acts for a very short time. So our cortisol in our body lasts like in the morning times. After you wake up, there is some amount of cortisol in the body. So by the evening it comes down, almost in the night it is almost zero. So it hydrocortisone dosing mostly like it is acts around 6 to 8 hours. So it mostly is comparable with the physiological normal body rhythm or normal circadian rhythm of cortisol. So hydrocortisone is around 8 to 10 hours, and the advantage of hydrocortisone is it doesn't cause significant hyperglycemia per se, and it is high, its bioavailability is very high. So one thing, it doesn't cause any hyperglycemia, it doesn't have any problem with the bioavailability, and it is not metabolized by liver. And one more, the main advantage of hydrocortisone is when you look at the anti-inflammatory and mineralocorticoid activity of the any steroid. Let's say hydrocortisone you take into the first account. First, hydrocortisone has an anti-inflammatory activity of 1, and actually normal mineralocorticoid activity is also 1. So they are 1:1, almost 1:1 ratio is there. So that is the advantage of hydrocortisone. So when you're looking at a case, let's say the patient the patient is in sepsis. So the patient is in sepsis, he's not recovering from the shock. You tried fluid bolus of 2 liters, you tried vasopressors, noradrenaline, you tried vasopressin, still the patient BP is not improving. So if you want to improve the blood pressure, you need some sort of mineralocorticoid action. Just anti-inflammatory action is not enough. So in such cases, especially when the patient is not recovering from the shock, you need some kind of pressor action of the steroid also. The mineralocorticoid hydrocortisone is a better drug to use. So in that case, because you can use 100 in the sepsis you generally used, the patient is not recovering from the shock, the dosage is 200 mg per day. The hydrocortisone dose is around 200 mg per day. You initially give a bolus and followed by 50 mg IV QID. That is 6th hourly you give. So that is how you give the steroid dose, and later on, after the patient actually recovering from the shock, you can actually gradually taper the dose of hydrocortisone and bring it to the normal physiological dose or stop it. So if you are using steroid for less than 21 days, you can directly stop it. If you are using it more than 21 days, you might need to slowly taper and stop it. So that is the importance of hydrocortisone. It has both anti-inflammatory activity and mineralocorticoid activity in the equal proportions. So that gives you an advantage when you're using it, especially when the patient is having shock or something. Hydrocortisone is a better drug. And also when you are having when the patient is in like, let's say it doesn't have significant anti-inflammatory activity also. Like, let's say the patient, you are suspecting some SLE or something, or some scleroderma or some Sjogren's or something. But you can't differentiate whether the patient is having some infection on overlap of it. So let's say the SLE patient is having some pneumonia or not, you are not sure. So you can't completely suppress the immunity per se, because you need immunity to fight the infection per se. So you can't go for stronger immunosuppression with dexamethasone or methylprednisolone without ruling out the infection in the first place. So in such cases, you initially give hydrocort, because hydrocortisone does not have significant immunosuppression. It has both balanced immunosuppression activity and mineralocorticoid activity, 1:1 ratio. When you compare with the prednisolone has a 4, like hydrocortisone has a, you take it as a hydrocortisone as a baseline. Let's say 1:1 is the anti-inflammatory activity of hydrocortisone. For the same dosage, you are using 20 mg of hydrocort for one. For the same doses, for the equivalent dose of prednisolone, that is around 5 mg, you get an anti-inflammatory activity of 4. That is 4 times more than the hydrocortisone. So that is why the prednisolone is a more potent anti-inflammatory agent when compared to the hydrocortisone. So, and also dexamethasone is almost 30 times more anti-inflammatory when compared to the hydrocortisone. So these are more, both prednisolone and dexamethasone are more potent anti-inflammatory drugs when compared to hydrocortisone. So hydrocortisone you mostly use when the patient is having some autoimmune condition and you're not able to completely rule out the infection in the intermediary phase until the blood cultures come back, or some procal marker, some sepsis marker you are using until they come back. In the meantime coverage for some anti-inflammatory activity, you can give in meantime hydrocortisone dose 50 mg TID or 50 mg, based on the 50 mg IV TID is what we use in the most of the anti-inflammatory. In meantime you roll out the infection. If it is a sepsis, your patient is needing the having shock or something, hydrocortisone is the drug of choice. So when do you use prednisolone? So prednisolone, there is an equivalent dosage for all the things. For 20 mg of hydrocort, you use 5 mg of prednisolone. So and for methylprednisolone, it's 4 mg. So the methylprednisolone action is for every, like for a 5 mg of methylprednisolone, it's 4 times more potent when compared to hydrocortisone at anti-inflammatory level. Let's say if you look at the table, the 4 times more potent than anti-inflammatory activity of the hydrocortisone, but mineralocorticoid is slightly less. Let's say there is one, you score a hydrocortisone mineralocorticoid activity as 1, the prednisolone mineralocorticoid activity is only 0.8. So it has something less mineralocorticoid activity and 4 times more potent anti-inflammatory activity when compared to hydrocortisone. So this is the drug we mostly use in the case of autoimmune conditions, like use it in ITP, use in autoimmune hemolytic anemia, use it in rheumatoid arthritis, use it in the SLE, use it in a lot of almost all rheumatological conditions. Use prednisolone because it has more anti-inflammatory action. It has some amount of like mineralocorticoid action also, and the duration of action of prednisolone is more, like it's around 12 to 36 hours. So almost acts for almost a day. So that is the problem. So why can't we use the prednisolone in the routine, like when the patient is let's say there is no autoimmunity per se, why can't we use it in the case of normal shockers? You can use it, but the hydrocortisone has one thing is hydrocortisone has a better mineralocorticoid activity and it has short action. It resembles our physiological cortisol levels, and it gives a time for HPA recovery. So if you give this long term, the problem with this long acting steroids like prednisolone, dexamethasone is they cause significant suppression of HPA axis. So it takes more time for HPA axis to recover. So that is why these are only used when there is significant autoimmunity per se. So you need significant suppression of immunity per se only when you are using. For routine purposes, you don't generally use prednisolone or dexamethasone. So in the normal day-to-day practice, prednisolone causes significant hyperglycemia. It also significantly causes, it is metabolized by it is metabolized by liver per se. So hydrocortisone is not metabolized by liver or anything. Prednisolone is metabolized by liver. That is why liver parameters also you need to keep in place when you are using prednisolone per se. So when this is mostly used, prednisolone is used in the case of pneumocystis pneumonia, it is used in the case of autoimmune hemolytic anemia, it is used in ITP, it is used in rheumatoid arthritis, it is used in SLA. So this is the important. It has more autoimmune anti-inflammatory activity, that is almost 4 times more potent than hydrocort, but slightly less mineralocorticoid activity. So what is the dexamethasone? So dexamethasone is something at the similar dose. When you use the equivalent dose of prednisolone of 5 mg, dexamethasone is 0.75 mg. So for that same dose, similar dosage of prednisolone, it is 30 times more potent than hydrocortisone. So it's almost 8 times more potent than prednisolone and 30 times more potent than hydrocortisone. So it has significant anti-inflammatory activity and it has zero mineralocorticoid activity. So that is the advantage of dexamethasone. So you use dexamethasone when you need significant immunosuppression. That is like you need a meningitis patient, there is a meningitis patient, you need a significant immunosuppression right now. So that you prevent any long-term hearing loss or significant inflammation-related damage in the brain, use it. Or significant ARDS is there, you can use dexamethasone or methylprednisolone because they are more potent anti-inflammatory condition when compared to hydrocort or prednisolone per se. So when you need a significant inflammatory suppression, so that is severe ARDS is there, severe cytokine storm syndrome is there, some significant HLH is there, hemophagocytic lymphohistiocytosis is there, or some meningitis is there. So in that cases, when you need significant immunosuppression, you use dexamethasone. So these are the conditions we use in the case of dexamethasone. It has zero mineralocorticoid activity and lasts for a long time. It lasts for almost for 3 to 5 days. So that is the problem. It has significant HPA axis suppression also. So why are we using in autoimmune conditions prednisolone? So always, so you need to decide on 2 factors. When you're starting a steroid, you need to understand there are 2 factors that are involved. So what dosage of steroid you want to start on, how long the patient requires steroid. So what is the need for the steroid? Let's say in the first case scenario, so there is a patient of sepsis with shock. You need hydrocort only for short duration of time. So you go for higher doses because hydrocort 100 mg or 200 mg use, that is very high, that is a very high dose. So because you need that now, because you need to improve the BP now. You are only using it for 4 or 5 days, that's it. So that is a condition where you use high dose for short duration of time. Let's say that take the same patient like rheumatoid arthritis patient is having joint pains and all, his inflammatory polyarthritis is there. So there is no need to use high dose of steroid in this patient, because it is not an imminent thing. You need to reduce inflammation right now. It is not something of emergency. So you can start them on low dose of 5 mg or 10 mg of prednisolone, and you meanwhile start methotrexate. Till the methotrexate take over, you can continue 5 mg or 10 mg of prednisolone, slowly taper it off and stop. So the importance is important. Unless there is an end organ damage in autoimmune condition, like there is lupus nephritis or some kind of vasculitis is there, you don't go for higher dose like 1 gram of methylprednisolone or 60 mg of some autoimmune hemolytic anemia is there, ITP, which is imminent. It is called emergency is there. You need to bring up the levels now. You need to control the inflammation now. Then is the condition when you go for higher doses. So otherwise, in the case of routine rheumatoid arthritis or some arthritis related, you don't go for higher doses. So that is the importance of dosage of importance. So coming to the dexamethasone, routinely used in the case of meningitis. Meningitis, the dosage of steroid is around 10 mg every 6th hourly, or if you want to quantify by weight, 0.6 mg per kg per day. So that is the dosage used in the case of meningitis. And dexamethasone has better CNS penetration when compared to methylprednisolone. That is why for all CNS cases, use dexamethasone better. For all respiratory cases, methylprednisolone is preferable, but dexamethasone can also be used in the normal day-to-day practice. It is because it is potent anti-inflammatory, especially in the case of ARDS. Even in the COVID also, you can use dexamethasone. So coming to autoimmune hemolytic anemia, let's say they take a different case. So meningitis patient is there, streptococcus pneumonia, meningitis is there. You want to start steroid in the first 24 hours, because you want to prevent the long-term effects of inflammation, that is any hearing loss or any focal deficits that can cause because of the meningitis. So you need to start at 0.6 mg per kg per day. So you need to start dexamethasone, because dexamethasone is a potent anti-inflammatory that controls inflammation now. So that is the most important thing that dexamethasone is used. And one more condition is used. I'll give you, there is a case of autoimmune hemolytic anemia with immune thrombocytopenia. So what dose you start, what is the drug you can use? So you can use either prednisolone 60 mg per day, or you can use similar like dexamethasone also equivalent dose can be used. That is 5 mg of prednisolone is equal to 0.75 mg of dexamethasone. That is also used. There are studies by American Society of Hematology. Previously, prednisolone is what we are used to give, but we can give dexamethasone also. Dexamethasone has faster recovery and better bioavailability, because it has long suppression of the immunity. So it faster recovery is there with dexamethasone. You can try dexamethasone also in ITP and autoimmune hemolytic anemia patient. It is not a contraindication, but this has potent anti-inflammatory action. So you should always keep in mind there is significant risk of infection or sepsis if you are not ruling out infection. That is the problem with using the potent anti-inflammatory actions. So these are the broad idea about the steroids. So hydrocortisone we generally use has similar mineralocorticoid activity and anti-inflammatory activity. We generally use in the case of sepsis with shock when it is not recovering, or some conditions like autoimmune condition where you are not sure whether the underlying infection is there or not. In the meantime, when you are ruling out infection, you can use hydrocort. And prednisolone has hepatic metabolism. It can cause significant hyperglycemia also. Both dexamethasone and prednisolone can cause significant hyperglycemia, but the hydrocort does not cause hyperglycemia. So prednisolone we generally use in the case of autoimmune conditions based on the condition. Like in the case of ITP and autoimmune hemolytic anemia, use around 1 mg per kg per day for at least 1 to 2 weeks, then slowly taper it off by 10 mg or something. And dexamethasone you use for short course in the especially when you require significant suppression of immunity, like the patient is having bacterial meningitis or ARDS or something. So let's say the patient was started on hydrocort initially, and patient has ruled out infection. You can convert it to the equivalent dose of prednisolone. Let's say you started on 50 mg IVTID, that is around 150 mg. 150 mg of that is around like 5 mg of prednisolone is 20 mg of hydrocort. So that is 4 times. So you divide it by 4. Let's say 150 mg by 4 is around almost 40 mg. 40 mg of prednisolone you can start. You can convert it directly to the 40 mg of prednisolone and you can use it. That is how. There is steroid conversion also you need to know in the case of, because you need to convert sometimes, especially when you initially start on hydrocort because of some shock or some infection, you can convert it to prednisolone when you need significant immunosuppression for autoimmunity. So these are the basic things. And coming into the uses, we use it in mostly PCP pneumonia. You start around 40 mg and slowly taper it off 10 mg by weekly and then bring it down. And in the case of meningitis, around 0.6 mg per kg per day for initial 3 to 5 days we can use. In ARDS also mostly 5 to 7 days we use, whether we can use methylprednisolone or prednisolone 60 mg or methylprednisolone 750 mg you can go, or you can use dexamethasone also. And coming into the other condition like autoimmune ITP we discussed, we can use it in the case of inflammatory arthritis around 5 to 10 mg per day of prednisolone we can use. And in the case of sepsis with shock, in the case of hydrocot, we use around 200 mg per day. That can be 50 mg IV QID or something. And we can use it in the case of intermediary before start in the case of autoimmune condition around 50 mg IV TID of hydrocot. And also we can use in the case of normal replacement, especially adrenal insufficiency patient, like the primary adrenal insufficiency patient, you need to put a maintenance dose of steroid, that is hydrocot 10 mg in the morning, 5 mg in the afternoon, or you can use equivalent dose 15 mg by 4 is prednisone, that is around 4 mg to 5 mg of prednisone also you can use. So once a dose, 5 mg, if you are using prednisone only one time is enough because it is long acting. If you are using hydrocot, it acts only 6 to 8 hours. One dose in the morning around 8 am, other dose 5 mg around 4 pm you can use in the case of primary adrenal insufficiency. So this is regarding the steroids use. So what are the possible complications of steroid per se? One thing is you need to, if you are using long-term steroids, one thing you need to realize is eye cataracts and glaucoma you need to check for. You look for hyperglycemia, that is one more complication. So how do you tackle hyperglycemia is that you match with that. Mostly prednisolone causes significant, like the peak of action is around 1 to 2 hours. So you match with it, just give NPH or something that lasts for 12 hours. So NPH or Detimer acts for 12 hours. So that will cover the prednisolone dose coverage. So when you are giving prednisolone, along with that you can use NPH or something small around 10 mg or 10 units or 8 units, so that it will cover up the whatever spike is coming. But even like dexamethasone or something, if you are using, you need a long-term coverage, but it acts for long-term. Something like Tresiba or Glargine needs to be used because they act for longer duration. So Glargine or Tresiba, you can start around 10 units or something, then taper it upwards or downwards based on the requirement. So that is why you mostly pair like dexamethasone or prednisolone with some basal insulin. If it's prednisolone, I prefer NPH. If it's dexamethasone, I prefer more long-acting like Tresiba or Glargine is what we prefer. And next thing is osteoporosis, especially if you are using for long-term steroids, you need to screen for DEXA scan. Any decrease in the bone mineral density needs to be screened for. And the next is the avascular necrosis of hip is a possibility. The next is the Cushing syndrome is a Cushing exogenous Cushing's is a possibility because of the weight gain. Stria will be formed, purpura will be formed. So that is a possibility. And so one more thing is it affects the immunity also per se. They are at risk of infection and all. So this all needs to be checked. You check for lipid profile, you check for sugars regularly, you check for eye examination regularly, you check for any osteoporosis there, you check for AV and hip is present or not. So these are the possible complications of steroid. So let's say a patient was started on steroid, he doesn't require steroid anymore. How do you taper it? So initially you bring down, let's say the prednisolone he was on 30 mg or something, he doesn't require steroid anymore, he's not in need, you need to taper it down. So you can bring it around 2.5 to 5 mg every weekly and bring it down to 5 mg in the, or how many weeks it takes. Let's say he's using 30 mg, or next 4 weeks you bring it down to 10 mg, and next week you bring it down to 5 mg by 5th week or something. After that 5 mg of prednisolone, you check for HP axis. So you stop for steroid for 1 or 2 days and check for 8 am serum cortisol. If it is normal, you can directly stop the steroid. Otherwise, you continue the steroid for small duration and again check for HP axis recovery. If HP axis is recovered, you can stop the drug. Otherwise, you need to continue the hydrocot maintenance dose or prednisolone maintenance dose. This is how you taper the steroid. And these are the brief uses where you can store steroid. How do you use the steroid? So for mainly based on the action, anti-inflammatory action is more for dexamethasone, which doesn't have any mineralocorticoid action, whereas prednisolone has around 4 times more than anti-inflammatory action when compared to hydrocot, but has little bit less of mineralocorticoid action. But hydrocot has significant mineralocorticoid action when compared to other steroids, and also anti-inflammatory action is little less. So based on this usage, you can use steroids in various conditions. Thank you.